This was the hottest topic at the Hand Society, probably because it's being pushed now by the makers of Auxilium, or the drug company Auxilium, and the makers of something called Zyflexa. So people will come in your office and probably be asking about Zyflexa. I'm going to talk about Dupuytren's in general. Moving quickly, first described in 1614, people thought the flexor tendons were drawing their fingers down. It's not a matter, it's not pathology with the flexor tendons at all. It's the gristle, the sinew, the fascia, whatever you want to call it, in your palm. By the late 1700s, somebody had figured out that that was the problem, and the first operations were done. And in 1831, Guillermo Dupuytren in France, who had a big publication, wrote an extensive article on it, so now it bears his name. Who gets it? People generally of Northern European descent, much more common in men than in women, and it's a disease of middle age in general. It's still thought that alcohol and smoking contribute. Epileptics, nobody's sure why. They think it's a side effect of the medication that people take, the seizure medication. And diabetics diabetics get everything, it seems. The pathology, the myofibroblast, is the cell of origin. And what it is, it's a fibroblast, if you remember back to histology, make collagen. Myofibroblasts make collagen and have contractile properties. And so over time, they'll slowly make that band of tissue become smaller and smaller, and that's where the contractions come from. It's known that type 3 collagen is the primary problem in Dupuytren's, which has some ramifications later. What you'll see macroscopically is you'll see thickening of the skin. You'll see people that come in with little nodules or skin pits. Skin pits are where the skin has become attached to that pathological Dupuytren's cord, and it pulls the skin and it pinches it and makes a dimple. You'll see cords that run between the fingers that draw the fingers together as well. The natural history is it does progress. Usually, the rate at which it progresses is variable, but it usually will get worse. A lot of people, it gets worse very slowly. It's not something people have to worry about. It does cause functional problems if you let it get to contracture. The distribution most commonly seen in the ring finger and the small finger, much less common on the other side of the hand. So bumps that you see on the ulnar side of the hand by the small finger and the palm, most commonly going to be either Dupuytren's nodules or volar retinacular cysts. Again, very uncommon to have cancer in the hand, not something people need to get all upset about. Dupuytren's diathesis is a little different. It's a form of the disease that's very, very aggressive. It's more common in young people, so if you see somebody who comes in who's starting to get a contracture at 25, 30, be very, very wary that it's going to be a problem. Disease in both hands is associated with rapid progression, people with a strong family history, and women. All of those things, when you see them, be very, very wary and talk about recurrence from the outset. Differential diagnosis, again, that bump could be a callus, it could be a cyst. The workup, physical exam and history, there's no plain x-rays to order. MRI studies have been done. Like everything, there's studies to prove what we want to know. They can sometimes differentiate the activity level by looking at the collagen differently, certainly not something that needs to be ordered. Nodular disease can sometimes be made better with a steroid injection. The results are very temporary, but it's thought that it can soften it, and for the people that have pain there, can sometimes give some pain relief. In general, it's a painful injection to receive, so I try to discourage people. I don't think that the benefits outweigh the discomfort. Early disease, watch it. Just leave it alone. The nodules and things, people don't need to do anything about them. 30 degrees at the MP joint is sort of the cutoff. So I tell people when they can start to see a space between their fingers if they look at it, that's when you start to think about maybe doing something about it. Before that, probably not realistic or not necessary. Disease at the PIP, or the first knuckle here, is much, much more likely to recur, and once it's established, much harder to get rid of. I tell people that have significant disease at that knuckle, at that PIP joint, that they'll probably get about 50% correction. Even if it gets straight with any of the things that we do, it's likely that they won't be able to maintain that. So we are more aggressive with the disease at the PIP joint. Now that things are getting less invasive, I don't know if the 30-degree contracture rule will hold or not. People will be more likely to have things done for convenience. The gold standard was always subtotal fasciectomy. In other words, go in and open up with a good-sized incision. The cords wrap themselves around the digital nerves the way that the specific tissue that's involved runs in the palm. They tend to wrap around the neurovascular bundles. And so the biggest complication from Dupuytren surgery has always been problems with either numbness and tingling or cutting of the nerve itself. But just getting the nerves out of the way and getting them untangled, so to speak, causes people to have paresthesias, at least for a while, if not permanently. There are lots and lots of problems with Dupuytren surgery. I don't think that there's any surgeon that you'll ask if they enjoy doing Dupuytren surgery. I think that they enjoy doing the operation maybe, but they don't enjoy the follow-up. The drawbacks, long recovery, probably 6 or 8 weeks they can plan on not really having great function in their hand, and then there's some disability associated with it. There's a picture of it, but the things I wanted to talk about, that I wanted to briefly tell you about at least, is the hot topic. So enzymatic fasciotomy, I guess this is a good time for disclosure. I was on the speaker bureau for Auxilium. I no longer am. I'll just give you my 2 cents. There's 2 ways to be less invasive with Dupuytren's. You can do a mechanical fasciotomy, or you can do a chemical fasciotomy. The enzymatic fasciotomy is Clostridial collagenase, and what it does is it breaks the bonds between the type 3 collagen fibers and, in essence, weakens the cord, and they come back the next day and you manipulate it. The bad thing about the enzymatic fasciotomy, or doing it with the chemical way, is that you can only give 1 injection per month because they're not sure what the side effects or the cumulative effects are, and it's $3,000 a vial. So you look at those 2 things, it's pretty expensive. The French in the 60s and 70s started doing mechanical aponeurotomies. I wasn't a big fan of them. I thought, oh, if you don't take the tissue out, it'll just recur. So mechanical fasciotomy is taking a small gauge needle, like a 25 gauge needle, and fenestrating that cord. So in essence, just like the enzyme does, you weaken the cord and then you manipulate it. The difference is if they have multiple fingers involved or multiple bands that are causing the problem, you can treat multiple fingers at the same time, and the cost is, I think, about $3.50 for a 25 gauge needle. So it's a huge, huge difference. So despite, like I said, speaking for Auxilium for almost a year, I don't use it at all anymore. I just don't think it's worth it. And I don't think that the risk of that foreign protein is worth it either, although I don't think that's significant. I do needle aponeurotomy now. I think it's becoming more and more popular. The recurrence rates are about 40% at 5 years, but again, the studies vary, and again, what people call recurrence varies. Some people say that 5 or 10 degrees isn't recurrence. They don't talk about recurrence till 30 degrees or something that they would do something about. Other people talk about any contracture. So it's hard to look at the studies across the board. The good thing about doing either the enzymatic or the mechanical fasciotomy is that if they recur, you can go back and do it again. So the take-home from this, there's no correct answer. It's not that chemical or mechanical fasciotomy are the right answer. At the Hand Society last week, there were still people that swore that the only way to do it is to take all the disease out. The argument to that is you're doing a macroscopic operation for microscopic disease. You're never going to get all the cells out, and you're not going to change the genetic makeup of the cells that remain, so you're not going to cure it. Recurrence is always going to be a problem. It's probably not a complication. It's a natural history of the disease. I leave it up to the patient. I let them decide. If they want to have an operation, I'll try to dissuade them, but I won't tell them they can't. I do not really give the Auxilium, though. If somebody was adamant, I probably would order it in. It doesn't cost us anything. I just don't think it's worth spending $3,000 of the medical system's money on something that we can do with a needle. So I've really transitioned, and I'll do almost all of them with needle aponeurotomy, even the revisions.